on antibody testing. Antibody testing has always been a procedure which does not yield much information, and it needs lots of information. But how do we process this information is always confusing. Some people feel that their antibody levels are high and they are going to go to the society without masks. Some people feel that their antibody levels are low, so they want to go for the another dose of vaccine. Some people want to know which vaccine to take. Some people want to know whether they can have a booster dose of a different vaccine. The scenario is absolutely confusing, and lots of things are circulating in the market. Daily new studies are coming, so we thought it better to have a talk about this topic, which has been confusing various physicians all across India, not only in India but all across the world. And we found that Dr. Sonal Saxena is the best person to talk about it, and she has been a prolific speaker. And I know that she hails from an institution from where I did my graduation and post-graduation. Very proud to be a graduate from London Medical College. And I welcome Dr. Mrs. Sonal Saxena. Dr. Mrs. Sonal Saxena is the Director, Professor, Head, Department of Microbiology, London Medical College. And she has not only the administrative responsibility of Department of Microbiology, but she has the state level ICMR nodal officer, COVID laboratory nodal officer, and the lab coordinator for Delhi's COVID-19 Zero Survey. She has been the recipient of various awards and fellowships, including the R.A. Bhujwala Award and the WHO Fellowship, and she has been awarded the best poster, How Safe is a Short Course of Potent Oral Broad Spectrum Antibiotics Among the Children. And she has delivered various orations and WHO spokesperson to develop the National Antimicrobial Stewardship Program, Government of Maldives. And she has published large number of papers. She has delivered orations. She has chaired sessions. She has written chapters in various books. This is very brief about her introduction. Only one thing which I wish to say is that when she wants to, she is speaking, everybody wants to listen. My friend, Dr. Raman Sardana, who is the secretary of the Hospital Infection Control Society, I wanted to invite him for the faculty for the another topic, but he said it is better to listen to Dr. Sonal Saxena. When she is speaking, everybody listens carefully and silently. So we welcome with warm hearts to Dr. Mrs. Sonal Saxena. And to chair the session, none other than Dr. Rahul Nethani, who is a immunologist par excellence and who has done more than 1,000 bone marrow transplants at the Saket Hospital. And our own president, Dr. Vijay Arora, who has been the director of the MEX Hospital, to chair the session and guide us all through the session. And to cut the long story short, I invite once again Dr. Mrs. Sonal Saxena to start her deliberations. Thank you, Mrs. Dr. Sonal Saxena. Welcome, madam.
Thank you, sir, so much for the kind words. And I'm very comfortable now because my teacher is here. Dr. Raman has been my undergraduate, postgraduate teacher, and I still my guru. So my first namaskar to him before I begin. And I can also see a few of my classmates logged in. So I hope I do justice to a very hot and burning topic. And I hope the end result, I'm sure, is going to be very different from what you had expected. So trying to clear some of the confusions that we have regarding antibody testing. And we've been working with antibodies for the past 7-8 months now. We have about 7 projects lined up, few of them with WHO as a unity project, few of them with DBT. And that this is something which is we are very familiar with, something which began on 31st of December when people were ringing the new year. And lesser we knew that all the new years are going to stop after 2019. So, and we are very familiar with this timeline and how all hell broke loose after March 11th, and we are still reeling under the same effects. And this is the little foe which has spread across barriers, across everywhere. And I want you to remember a few things as I take you down its microbiology. One fact is that it's an enveloped virus, thank God. And it's got a few structures which have come in useful when we talk about the antibodies. One is the spike. What is a spike? The spike is its organ of attachment. It's something what the armor that this soldier has to attach to these receptors which are expressed throughout our body. And physicians know best about these receptors. I'm not going to tell you anything about it. What I'm going to talk about it, that there is an envelope which is non-immunogenic, there is a membrane which is non-immunogenic, and there is a nucleocapsid which encloses this RNA, which is highly immunogenic. So taking it further, this is the area that we are going to concerned about. So let's see a little bit about this area as to why we are concerned about. It's a flower-like tricuspid structure, and this is the area which binds to the ACE receptors, or is known as the receptor binding domain. So there are two subunits, as I said, the S1 unit, which is responsible for binding to ACE, and the S2 unit, which is responsible for the finally fusing the whole virus with the cell membrane. So here this S subunit has got two things, N-terminal domain and a receptor binding domain. So without confusing you any more microbiology, I will just say that we will just take a little step forward and remember these, that there is an S1 and then there is a receptor binding domain. And why we have discussed it in so much of detail is that spike is highly immunogenic, but it also has a neutralizing activity. So any antibody which is against this S or spike, then it will have the capacity to neutralize the virus. Any antibody which is specifically against the receptor binding domain can be very strongly linked to viral neutralization. Now, this is so much so about the spike. The nucleocapsid protein is something which is responsible for the viral replication and assembly, and it is abundantly expressed during infection because it's a main part of the virus multiplying. So the expression is very high. It is highly immunogenic. It induces the antibody production, which is earlier than S, but it does not produce neutralization effect. It is there. It indicates that the virus has multiplied, and that is what has given rise to these antibodies. The N gene is more conserved, but there are limitations that these assays, they are more stable, but the various number of studies have shown that they may be binding, but they are not neutralizing. The S-based assays are that they usually measure the total antibodies, and how this they do is, I will come to that later on. So functionally, we are all familiar with the IgM, IgG, IgA. So going back the slide, what we saw, how a spike is there and our receptor binding domain is there, and a nucleocapsid protein is there. And all these areas are going to elicit antibody production in us. First would be the anti-nucleocapsid antibodies, which will come very fast as the virus starts to multiply, the body starts to respond. And then come the anti-spike antibodies, which could be anti-S1, which could be anti-S2, but the most important are anti-receptor binding domain. Only when the antibodies are against that domain, they are neutralizing. But it is not essential. All neutralizing antibodies will be anti-RBDs, but all anti-S or anti-RBDs may not be neutralizing. So we have to remember this, and as we go ahead, it will answer a lot of questions that you have generally in your mind. Now, just like any other antibody response, this is also similar to that. The IgM rises first within a few days, 5 to 7 days of infection, then starts the IgG. And if you see this, why this is important is this arrow is the onset of infection, but this is a window that I am most concerned about. So any person who's measuring the total antibody, just look at this site here. IgG has just crossed the detection limit. That means it has started to produce, whereas the IgM is very high. So that means that any kit which measures total antibody will say, oh, you've got this much antibody titers. But in reality, they are very short-lived IgM antibodies which are going to go down within a few weeks. So the total antibody, if we measure, we are going to be stuck here, because you will have IgAs also, which many studies have now shown that IgA is higher in severely ill patients, because probably the ACE receptor expression is maximum at mucosal areas, and so the mucosal immunity is highest. None of the vaccines have addressed this issue till now. Only the nasal vaccine can address this issue of production of IgA. But the advantage of IgA is that it gets secreted in the breast milk, and that's how usually the infants remain protected. Then the IgG, which has a neutralizing activity, but IgM doesn't have neutralizing activity. And so the take home message from this slide is that if you do total antibody assay, it will confuse you. So moving ahead further, this was a paper which we published recently in a Japanese journal, where we found that the highest seropositivity found in the administrative staff. Imagine now, this is our own hospital, Maulana Azad and LNH hospital. And we had a huge number, 1,400 employees, which included 1,217 health workers. And we found that the administrative staff had the lowest, possibly that they were, exposed more, and they were not sick. They were all asymptomatics. And the lowest was among medical doctors. And this was statistically significant. This could probably be due to the fact that the doctors were a little more cautious. They were more compliant to hand hygiene and PPE than the administrative staff. This was higher with people who lived in containment zone and with males. Non-pharmaceutical interventions were not associated with a reduction. You should go, I've given the reference, you should go back and read this. Just read the last part of the discussion, where we found that there was people who were taking all these, non-allopathic drugs for this, for prevention, for, ki hame hoi na COVID. They all had very low antibodies. So they were at a very high risk, and they believed that they were, very much protected. Then came the spike and NCP based antibody assays. Now, these are the ones which we are bothered about, the neutralizing antibodies, which is actually an immunoglobulin that independently blocks the viral entry into the host cells. And it is the NAB assessment which indicates the protective immunity, both in serodiagnosis and in evaluation of convalescent plasma therapy, and in vaccine development and responses, even in monoclonal antibody development. So it is this what we are concerned about. But we have to remember this, that not everybody will develop neutralizing antibodies. Secondly, the level of prevention offered by these, we are still very new into this disease. So we don't know that what is the level of protection offered by which titers of neutralizing antibodies. And we also right now are very shaky about the duration of protection of these antibodies. Only recently in May, there is one study which has been published, which says that the antibodies persist for 9 months. If you link these with severity, it was found that neutralizing antibodies were mostly seen in mild patients after the 3rd week of illness, even if they were asymptomatic but RT-PCR positive patients. Pneumonia patients showed a shorter seroconversion time. This is from these 2 studies, the findings. Then higher antibodies were seen of the neutralizing in nature in 31 to 84 in younger patients. These are basically the meta-analysis and review articles that have found these, which after combining a lot of studies. Then these variables of kinetics is very similar. IgM switches to IgG. That's similar, but there has been contradictory report. A study from Wuhan said that this variability, they found that both IgM and IgG rise together, but later on it was found that it was not happening in majority of cases. Then recently this March 27 study is what I'm talking about, where they found that neutralizing antibodies in people who have got infected persist for 9 months, although their titers go down to a very, very low level, and which may not be detectable by the routinely used assays. The durability of these and how they are correlating remains unclear. And this was one study very recently reported where it said that 80% are protected from reinfection. That's a huge Denmark cohort of millions of people, which said that 80% were protected from reinfection. but this protection went down to only 47% amongst people who were 65 years of older. So this actually helps in strategizing the vaccine strategy as to why these people were preferred for vaccine in the initial stages. Then probability of predicting these responses will be enhanced if the S1 or RBD is used in the assay. And I'll come to these assays and you will come to know that there are very few assays which actually detect the antibodies to S1 or RBD. These are relatively high and an early antibiotic response is targeted to the S antigen, which was elicited in patients with COVID-19 compared to the N antigen. So it is there. And this is another study that we did with THSTI. This was published very, very recently in American Journal of Tropical Medicine and Hygiene. A very, very extensive work where we followed the patients who were admitted in our hospital, which being a largest COVID hospital of Delhi. So and here we followed these patients for a very long time. And what we found was that the proportion of serological response increased with the severity of disease, which is quite expected. And the participants with severe disease, almost all had severe disease if they had serology positive. But in mild and moderate infections, about 90% were positive, and about, you can say, 78% were positive for asymptomatic. Even the asymptomatic, 80% had IgG antibodies to RBDs. And this is specifically that we measured the RBD antibodies and the nucleocapsid separately. But these were also not measured as neutralizing antibodies. Now, this was another work from very early during the stage where they found that in the critical patients, these antibody titers were very, very high. Whereas in the non-critical patients, either they went down or they were not, or they were maintained at a particular level. Now, there are various platforms which are available for antibody detections. We have chemiluminescent assays, we have ELISAs, we have radioimmunoassays, which are rarely used because of radioactivity hazards. We have rapid assays, which are like lateral flow assays, which are very, very popular now with the antigen testing, but were extremely unpopular when they were launched in June. I remember on a Sunday, we opened our laboratory to do training for healthcare workers, which were posted in community, and for the lateral flow assays for antibodies. And within 2 days came that ICMR had withdrawn those, and all those had to be returned to CPA, all the kits. So we've come a long way. Now ICMR has approved a few lateral flow assays, but generally lateral flow assays perform poorly when you compare it with Chemi and ELISA. Why CLIA, or as we say, call it Chemi in our language, is better is because it allows a better estimation rather than giving you just a qualitative detection like a positive or negative. It allows you a quantitative detection. It is less error prone. It's an automated system. It's faster and it has a higher TAT. So if you want to do for a sero survey, say 2000 samples a day, ELISA would be next to impossible, but you can do it in a CLIA. And obviously, we always go for a better technology. But there are huge variations. The variations can be from kit to kit, from assay to assay, and from machine to machine. And sometimes the same sample, if you put it in one machine, it will give you a different result, and another, it will give you a different result. My own sample, which I took at the time of my second dose of vaccination on 18th of February, I put it up with one ELISA that we had, and the report came negative for antibodies. So I was like, okay, my first vaccine dose has not worked. Same sera was put in another kit, and I got an antibody index, not titer, an antibody index of 14. That means 14 times the normal. Same sample, same time, same sera. So this variation is sometimes mind-boggling, especially for practicing physicians. Then higher antibodies will not suggest anything. They don't suggest immunity. They don't suggest a longer lasting immunity. So the purpose is lost. So the purpose of saying that higher antibodies are going to protect is not there. Then for convalescent plasma, when this convalescent plasma was being used, the neutralizing titer of 1:320 or more was considered, enough for you to give that plasma. So we have a different variations, and we have different ones, and all these platforms which uses, we are concerned about either the antibodies to nucleocapsid protein, antibodies to spike, antibodies to RBD. And these could be total IgM, NGG, IgA, or it could be IgG, or it could be IgA. Then there could be just binding assays, which most of these assays are, or could be neutralizing assays. Now, technically, neutralization assays are done with plaque neutralization. And plaque neutralization is an extremely complicated procedure which requires BSL-3 facilities, takes about 2 to 4 days, and it's very dangerous because it needs maintenance of a live virus and trained manpower. So then came, let's use nowadays we use surrogate for everything. So let's use a surrogate for viral neutralization test. That brought down some kind of equipment and some kind of manpower, but still a very, very technically demanding test. Then there was this CPAS SARS-CoV neutralization antibody test, which kind of detects the neutralization antibodies specifically. It detects by a competitive ELISA, as we call it, and it detects the a test. This has been patented by Dr. Lin Fa Wang lab, and this is marketed as CPAS COVID neutralization test. This was the first one. But what are the technologies? Let's move on to CLIA. This may sound a very complicated picture, but this was just to show you that so many platforms are available, and there are various platforms and various principles attached to it. For example, this is the OCD, or not the OCD of psychiatry, but the orthoclinical diagnostics of in microbiology. They make a CLIA system which is called VITROS, and they have an anti-SARS-CoV total. They have an IgG. Then there is an Abbott architect, which became very famous in between, that it was the only one which gave anti-spike S1 RBD immunoglobulins. Positive was at more than 50 AU. So they were semi-quantitative. Similarly, there was another one which is very important. There is one from Roche, there is one from Diasorin, which is an anti-spike S1, S2 IgG. And what is important with Diasorin is that the company claims that they have 94% correlation with plaque neutralization assay. So it correlates very well. So the detection above 15, it is a quantitative assay which tells you that if your levels are above 15, then they are neutralizing antibodies. Then they have a trimeric CS, which is with microneutralization assay. And this is the one which is being marketed, I think now. This is the older one. Then another one, Siemens Italica, is what we were also using for some time as a trial mode, but we were not very comfortable using the machine as it gave only an index. Most of these you will find the cutoff is either S by C or COI or things like that. This is actually a way to determine in our laboratories. In a layman terminology, I can only explain that this is a division of the positive sample to the to what we see, the control. So whatever the machine control has, it's a ratio of that. So anything above 1 means that the sample is positive. And then we have various ELISA kits. The first one was the Kavach ELISA, which was essentially, as one of my junior put it one day, that I asked him when the Kavach ELISA came, and I said, we are getting some Kavach for validation because we have a lot of patient load. So we are going to take in the samples and let's see how this Kavach pans out. So he read about it and he got back to me and said, ma'am, ye to virus ka nichod hai. So it's like it's the whole inactivated virus, all the antigens are expressed. So it's got a mixture of a total assay. It's called a total IgG assay. When it came, it was total antibody assay, which was completely qualitative, which measured anti-NCP, anti-spike, anti-RBD, everything in one go. It still measures everything. It doesn't measure separately. Then there is a one-time total IgG IgM assay. We are working with this. It's an excellent kit. and it is a semi-quantitative assay. So it gives you an antibody index. So suppose your index is 14, the normal is 1. So that means that you've got a little more than about 14 times the normal.
Yeah. Huh?
Then we have a few from CalBiotech, Euroimmune, these are all. The only neutralization assay is from CPAS and Sinobiologicals, and only last 2 weeks ago, I think, Jmitra, the Indian company, has launched this neutralization assay as a Make in India neutralization assay for the first time. Then there is many of us have got this machine. We also have it in our hospital, which is a Vidas from bioMérieux, which has an anti-SV1 RBD, and it gives a semi-quantitative analysis. We have not yet started using this machine, so I don't have any experience with it. This was another paper that we did with another work that and this is still ongoing, which we did with DBT, and DBT made an Indian consortium where myself and the people from Maulana Azad were part of it. 3 of us were part of this, and this was published in a very prestigious journal of clinical virology. We were part of this consortium. This was again THSTI DBT Institute. And here we found that we compared 3 assays. One was the diazorin assay, S1 anti-spike S1 NSG, which measures this according to spike. And we covered the Zydus Kavach ELISA, which is marketed by Zydus. And we found that the sensitivity was pretty good for these. Even Kavach showed a specificity of 99 and 100, and they showed a extremely very good agreement. But they were able to, Kavach was the lowest in this, but the RBD ELISA, which TSSTI made, that and the diazorin ELISA worked very, very well. So we were quite happy with these results because it was both, they were both in-house assays. Then coming on to where these, we've talked so much about the anti-spike proteins, and that is how these vaccine targets were identified. And the only reason I've included this slide is that I get a lot of questions when people ask that, does my taking Covishield produce NCP antibodies? So, and many times you must have seen that you take a vaccine and there are no antibodies, because the kit that you use to measure post-vaccine, you took Covishield and your kit is measuring only NCP antibodies. So you'll not get anything, because all these vaccines except our own Covaxin gives you only anti-spike because you're using only spike, so it gives you antibodies only against spike protein. So you have only anti-spike antibodies. It is only Covaxin which gives you some amount of anti-NCP also. And all these, they have measured neutralizing antibodies which have gone up into hundreds. And they have also measured the T cell responses, which is, many a times we are all inundated with questions. Why these T cell responses? So this T cell responsive is also being measured at the time when we've had. Now, I came across these few Indian studies in the past few days. They have got published, and it is this study, the second DOI, which is still non-peer reviewed. It's available on medXRV, which has generated quite an uproar by saying that the after first dose, only 43% of Covaxin seroconvert, and the mean titer is pretty low. Whereas after the second dose, the first DOI is from the first study, and the second is when they finished the second part. This is from Kolkata. So I think a multicentric evaluation, where after the second dose, they found that more than 98, almost 100% people seroconverted, whereas, in Covaxin, 80%. And this has created quite an uproar. Look at the mean IQR. Then another study which showed that antibody response developed only after 14 days or later of giving the vaccine. And the second dose was associated with further increase in antibody levels at day 45 compared to day 28. But immunity is not guided by the humoral arm only. And that is what the Covaxin manufacturer has tweeted yesterday, saying that it's not just the antibody that you can measure and say that my vaccine is low. Nobody likes to call their child bad, even if it's, Even the Gabbar Singh's mother would have said, my son is the best. So to conclude, if you look at the immunity in SARS-CoV vaccine, sorry, this has been taken from an American site, so that's why it says the mRNA vaccines, we will have neutralizing antibodies as well as memory T cells, and both of these together will give you a protective immunity. And just a few words before I wind up about what is causing why there is an uproar, everybody wants an antibody testing. Obviously, it assesses the prior exposure and infers potential immunity. Sometimes you may not know. You must have seen all the patients who are, like in our hospital, whenever we go to a non-COVID portion, like we went in January, February, and March, what happens is that all the surgeries, you screen patients for RT-PCR. So this time, for few patients, we screened for antibody also, and we suddenly found that the patients who were not RT-PCR, that time RT-PCR was negative, but their serology was positive, and they came out and said, we've never had any disease. So maybe you infer a prior exposure, you can assess. For epidemiological purposes, estimation of attacks rate, R naughts, and case fatality rates. If you want to measure the impact of control measures, the sero survey before lockdown and after lockdown will actually give you some amount of how much people have not been exposed or exposed during this. Then obviously identification of plasma donors, looking research for monoclonal antibodies, and assessment of vaccine immunogenicity, pan-corona therapeutics and vaccines, and also for identifying potential zoonotic disease transmission. I really want to know who took that lion sample in the zoo. So what causes the virus to change? This is the latest, today morning only we had a genomic surveillance meeting where India is making a huge program of genomic surveillance, and there are various variants which thankfully WHO has named according to this. And why these changes matter is that this is the size of the protein and this is the unit. And you will find that in what we are concerned about is this. The receptor binding domain is 319 to 541 base pairs, and it is this that we are concerned about. So any change which occurs in receptor binding domain, this to this will change the virus binding because it will change the spike protein. So we may have heterologous vaccines very soon which are going to target this. And how these variants are affecting is it's a lecture by itself, that these variants, how they change. But just remember, this was, I think, in some newspaper in the national news, where if the effect is the variant is more transmissible, you definitely need more people to be vaccinated to achieve herd immunity. So the figure which was originally 65 to 70%, our policymakers should note this, has now gone up to 83%. So on the Delta Plus variant, which just came a few days back, I think we'll go up to 90%. So we need to vaccinate actually everybody. So the ability to detect neutralizing antibodies can help us gain an additional insight into what this means. And patients should not interpret the results as telling them that they are immune or have any level of immunity from the virus. This was from Tim Stenzel, who's the FDA expert on this. So I just hope I've cleared some confusion. I don't know about the confidence. So that's it. If there are any questions, I'll take that.
Thank you, Dr. Sonal. I think you have very lucidly covered all the aspects, and I would say that it has caused more confusion.
Okay,
more is the knowledge, more is the confusion. Anyway, Dr. Nathani, who is an immunologist and who has been seeing a number of patients with very, very poor immunity because of bone marrow transplants, he wants to know some questions. Dr. Nathani, may I invite you to ask your questions, please?
Yeah. So I think the session is open for questions. I have put in few, but other people could also maybe type in their questions in their chat box, and I can set the ball rolling. So for an individual patient, so the clinical trials and some specific populations aside, do we need to do antibody testing at all for an individual patient?
No. There is, see, when we do antibody for any test, like when we do for typhoid, when we do for say any disease per se, what happens is that we have data which is lasting decades. So we know that this is the population level and this is the level of exposure and this is how that you are acutely infected. But if you look back into microbiology, how useful is Vidal test? How use in your diagnosis, in making a diagnosis? How useful is dengue antibody? And all of these came with a huge bang. They said that, oh, we found antibody test to dengue. But within few years, we had to switch to NS1. So antibody tests are never there. They are never used for diagnosis unless and until we are looking at a disease which has a long incubation period like HIV. So there we know that yes, the antibody levels have developed to such an extent that yes, they were going to remain. Hepatitis B, and we know their kinetics, that they remain in the level for such a long time. Here the disease is only 1.5 years old. We hardly have any data, and what we have is a very conflicting data.
So I appreciate you being very clear and straightforward about saying no to antibody testing. Now, one more question. Why should we vaccinate at all the people who have been already confirmed COVID positive? So not suspect, but confirmed by RT-PCR. So why are we suspecting that natural immunity will not last? We do not vaccinate patients, having other viral diseases. So why COVID? Is it just lack of understanding, lack of data, so vaccinate everyone, or there is something more to it?
We believe in evidence-based medicine. So our evidence says that the natural antibodies, I have said in my presentation also, we actually don't have that much data which says that to how long the antibodies are going to last. So one is that. The other is that there is recently, I just read about 2 days back, one article which said that if you give a single dose after to those patients who've who've tested positive, confirmed, it gives you the titer as good as 2 doses of vaccine, because one acts as a booster. The infection itself either acts as a booster or the vaccine acts as a booster. But the thing is, suppose first patient X was positive in April and he gets vaccinated now, then he will need 2 doses, because maybe his memory would have gone finished, or even the chickenpox vaccine, when you give, you say that after 20-25 years it loses its body forgets. So that could be one reason. The other is probably it was a logistic issue, that how to identify, how to pick out those people, and it will bring in more hesitancy. So it was, I think, a policy decision that okay, let's vaccinate everybody.
Yeah, I think so. So that also, brings out this point of the booster, that what fun having that booster when the antibody titers do not mean much. So somebody may have a titer of 20 and somebody may have a titer of 4,000. We've seen titers up to 20,000, and
actually in COVID, it's not yet, we have not reached the stage of booster. This is a primary vaccination which the manufacturer says needs 2 doses, right? So the manufacturer says it needs 2 doses, 28 days apart, we go by that. Then the manufacturer brings in more data and says we can now increase this to 84 days, and we go by that. So it's the manufacturer's data which says that we need to give 2. Primary immunization is 2 doses. It's not acting as a booster. So pardon me if I use the term booster. What I meant to say was that the antibody titers will increase, but so will the memory cells. There is so much of redundancy in medicine that you read about brachial artery in anatomy, then you read again in surgery, and then you read again in radiology. Why do you keep teaching it again and again? So that the child remembers, because it's such an important thing. So as a teacher, I can only tell you that things get repeated. So similarly, we are trying to train our immune system and our memory cells by giving repeated exposures. So that's how the vaccine has been built.
So maybe
can I
take over?
Yeah, Dr. Rahul, can I ask one question?
Yes, please.
Yeah, so actually excellent talk, madam. You showed our study, that is the COVID-2, I am part of that. Rather, I am one of the author of that.
The last study.
Yeah, COVID study. So we have already sent for the peer review, and as you know, when this study was published, there was a Twitter war. So, but
read that.
in our conclusion, you must have read that we have not told anything against Covaxin or Covishield. Rather, we also showed that the response with the second dose of the vaccine, post-vaccination with Covaxin was quite good. And as far as the breakthrough infection is concerned, I think in that definitely the Covaxin scored much better. So still we are under peer reviewed, so we'll not talk much about that. But I think we are doing the third sampling, and we are also planning. We are not. It is in our protocol that the last sampling will be done in the September. So also we will be able to see after 6 months what happens to the antibody titer. So that is one part of. Then I think the final conclusion can be drawn. But one question, my very important is that some people ask that. We are doing anti-spike antibody. So does it gives the, as you already cleared it, that this doesn't give a passport that you are fully protected, or it is something like just like neutralizing antibody. But you also showed one study where you showed that there is at least some resemblance if you have got a good antibody titer, anti-spike antibody, it also matches to some extent. It gives you that is some antibody, that the antibody is giving you some immunity, but it is again very debatable at present. As Dr. S.K. Gupta also wrote very well in our COVID update, that it doesn't give you any guarantee you are protected and how much that will help you. But anyway, till that, I think the anti-spike antibody is a very good antibody, which is possible to do. We also plan to do other antibodies or something. It is, I think, no study is doing this cell immunity assessment. So we don't know what is happening exactly. But I think yeah. So what is your opinion on that?
Sir, I think that the phase 3 trials and the extended phase 3 trials which Covaxin is doing, I think they must be looking at cell immunity right now. I have not read anything to that, but there were a few studies which I found where people have actually looked in at the T cell, and right now in my college also some student has initiated a PhD thesis on this in post-vaccine subject to see a T cell response. It's a little complicated and an expensive proposition, but maybe people are working on it, I think, and we'll have some results later on.
Yeah.
Because we are in vaccine, we are as good as the year is. So we are just 5 or 6 months into this vaccine. So right now also, but sir, which kit did you use to measure in your this thing? Did you
We
use
already showed that kit, that is
diazorin?
diazorin. So we used
So
that kit.
because diazorin has got the best correlation with neutralizing assays.
Yeah.
So if you, since yours is under peer review, and I was quite, I read your full article and I was quite impressed by the way it's been analyzed and said, and it's a mere observation. You've not done any, per se intervention on your own. But
yeah.
we are also working with on a WHO Unity project. The results are yet to be published, so I can't share it. But we've also found similar results because we also had both the vaccines, and we are now getting Sputnik from next month. So maybe we'll compare that also.
Yeah.
So let's see. I think these are all for the benefit of all of us. Anyway, the company doesn't claim more than 80%
Yeah.
protection by itself. So they should not be complaining. And
Okay, thank you.
Now I'm going to ask like a patient. It is very difficult to ask like a doctor. And the patient says, because there's a momentum set up in the society that we want to go for antibody testing. Can we have a guideline for the patient that if you have got a co-vaccine, then you go for this kit. If you have got a Covishield, then you go for this kit. Or if you have recovered from the infection, then you should go for the antibody. In case you want to go, though we discourage you to go for that, then you go for this kit. Or if somebody comes out with a result, somebody says that he or she got vaccinated by Covaxin and they got a test done by the diazorin, which in 2 people in their family shows a positive result, a good antibody titer, but in third person, who is also a young person, shows a negative titer. What answer do we give them?
Sir, it's a very complicated issue. It has happened in my own family. Me, my daughter, and my husband, in spite of being vaccinated, got infected in April, landed up in hospital also to that extent. And 2 days back, we got our antibodies done. All three of us have got very high titers of antibodies. But my in-laws who stay with us 24/7, who were vaccinated with another vaccine, same vaccine as my husband, not mine was different. They have zero titers. So I faced this in my family also, that ये vaccine बेकार थी या हम बेकार हैं, क्या हो गया? So this is a very common observation which you will find, and this will be there more in people who have comorbidities, who have dysfunctional immune response due to some reason. They have gut dysbiosis because the whole feeding of immune system is fueled by gut. So what happens is that this is just a theory, and as a theory, as my CV you said, I work more with antimicrobial resistance. So this is a theory that the gut dysbiosis, because it is known to be related to cause imbalances in immune system, every person is not taken care of by vaccine. The only issue is we never measure immunity post BCG, we never measure immunity post chickenpox, measles vaccines. So we don't know how those people respond to vaccine. Plus, the manufacturer themselves says that their protection, except for Pfizer, which probably gives 97%, no other vaccine gives protection for more than 80-85% for COVID.
Will you advise testing by a different kit to those patients who have got a negative report by some other kit?
Sir, it depends, because if something will look after the total antibody, suppose a person is negative by diazorin, then he might say, okay, I will go for a total antibody. Total antibody might be there because there may be anti-nucleocapsid antibodies, especially if he received Covaxin. So this is going to go on, and he's going to go lab shopping. So that's not going to end anywhere.
See, when it comes to like kit being released in the market, then the producer is going to talk about the very high titers of the neutralizing antibodies. Suppose very shortly we're going to have the Novavax vaccine, about they have been boasting about the very highest titers of the neutralizing antibodies. On the other hand, we say that the neutralizing antibody titers do not correlate with the duration or the level of protection. How do you correlate both of them? Like, is it just selling tactics to the vaccine or to the kit?
Dr. Gupta, I showed you the slide where all the vaccine manufacturers have given the data. There's, this much. None of them is going beyond 850. That's with Pfizer. The neutralizing antibody titers with Pfizer and Moderna are the best, and they are also not going beyond 800. So it's more of a, not that, but actually it's a gameplay of statistics. You have a curve, bell-shaped curve. So you will have people who are at very high titers of antibodies, but you will also have people in the low zone. And when you do the average, they will tell you it produced antibodies up to 850, but will not tell you that it produced 53 also. So it's a kind of a selling point.
That's true. Madam, there are some people who are going abroad. They want to go abroad and they have taken one dose of vaccine, which is not yet approved in USA. And what is going on about these people? They are likely to face some problems over there in the passport, like a visa or the entry of the entry into the USA.
I think till right now, no country has imposed this restriction that you have to be vaccinated. You should have a vaccine passport before entry, but the countries will soon be doing it. And going by the media reports, I think by July, even Covaxin will have WHO approval, because they've also submitted their phase 3 data. Because the phase 3 data was not there and it was authorized for emergency use, I think that's why it was approved in a trial mode. So I think that's why WHO is taking time to approve it. But any vaccine which is, and it was an indigenous vaccine to India, so India will have to defend its pitch. Whenever something is produced in a developing country, that country has to defend its pitch. So I think very soon it will be approved. Right now, I don't think any country is returning travelers. The only thing is that people are returning because they do not have a QR code on the RT-PCR report and they are made to wait 72 hours and spend your own money and stay in an airport hotel and not move out if you don't have a QR code. So that problem has been sorted in the past 1 month by the ICMR report itself now comes with a QR code.
Madam, the breakthrough infection study which was done in the Maulana Medical College and other places, that shows that the healthcare workers, they got infected up to 39 days. The medium interval was 39 days post second dose. Does it
Actually,
indicate that the people remain susceptible to the infection up to 39 days, and it is only the cell-mediated immunity which works in these people?
oh, I think if you look at these were mainly, there was no antibody done. This was mainly a telephonic paper. Those healthcare workers were contacted, they were asked their doses of vaccination, and even the RT-PCR portal that ICMR, it gives you the date of vaccination now. So that is how we calculate, retrospectively calculated that. The thing is that even the vaccine manufacturers say that 2 weeks after the second dose, before that you are not protected. So they have kind of, safeguard themselves with FDA and with CDSCO saying that 6 weeks from the first dose or 2 weeks after the second dose. So for Covishield, that is now increased to 2 weeks plus 84 days. So nowhere do they say. So 39 days, especially during that time in Maulana Azad, there were 1100 patients admitted with COVID with a daily, there were a footfall of about 600 patients a day. We were getting 550 to 700 results, RT-PCR per day in our department. So that was a time I just, God forbid. So maybe at that time, more people got infected in spite of vaccination because there was so much of exposure.
That's true. There is a question in the chat box: is it essential or is it mandatory? Is it desirable to get a CRP test done before a vaccination?
No, I don't think so. You people are physicians. I don't think it is. It doesn't make a sense. Many people have asked me this, but it doesn't make a sense. CRP is an acute phase reactant. It only tells you even if there is an inflammation in your body, what has vaccine got to do with it? We never do it in children when we give them the vaccine. Do we do it? This is also same vaccine. And Covaxin is a standardized whole inactivated vaccine. It's not something like mRNA which has come for the first time.
Some people, they want to know whether is it good to take aspirin along with the vaccination, second dose, second dose of the first dose.
Sir, I don't know. This is probably related to the clotting incidences which have occurred, but technically, I feel that those two mechanisms are totally different, and aspirin doesn't work on those clots. So I think it is just a fear psychosis that people are doing that. I don't think there is any data to support.
Was Covishield for us healthcare workers? Were we guinea pigs to Covishield initially because
I don't think so, sir. I have as much faith in Covishield as an Covaxin.
No, the duration I'm saying, because it has become 8 to 12 and 12 to 16 now. So it was 4 weeks for all the healthcare workers. So there were a lot of breakthrough infections in the healthcare workers. So could that be a reason?
Sir, actually, why they have increased now is if you read the original study which recommends from England, they have been recommending it from February that you can increase the duration of interval to 84 days. That study in UK found that you can increase the duration to 84 days. The issue was that in India, at that time, we did not accept their this thing, and probably the policymakers were in a hurry to, I would privilege rather than say guinea pigs, that the country thought that the frontline workers needed first. And I don't think we were made guinea pigs at all. There is a data which now says, possibly the reason behind this data is that we mount antibodies to adenovirus. So when the second dose comes early, what happens is that our antibodies which are there, now Covishield is an RNA which is put inside another adenovirus. So if you attack the adenovirus, our ready-made antibodies after the first dose, they attack the this thing, and this is one of the hypotheses. So if you increase the duration, those antibodies go down and the efficacy is better. So in EBM, everything has got evidence. Now we have evidence that it works for 84 days. So I think that's why.
Dr. Last laboratory is doing neutralization antibody, neutralizing antibody
I think
testing.
many are doing. Apollo is also doing. Gangaram is also doing, because they have diasorin to har jagah hai aajkal.
No, Dr. Lal laboratory is doing for 4,000 rupees. The turnaround time is 48 hours.
See, now J Mitra is selling. So if J Mitra has come now, every lab will have, because it will not be imported now. So there will not be a shortage and imports and embargoes and all that. So now I think in another 15-20 days, only today I was talking to his sales guy and he said maybe by end of next month, they will be in full supply.
Dr. Pankaj, you want to ask some question?
I want to ask one question, ma'am.
Yes, sir.
When we talk about herd immunity, it is the vaccinated people or the after natural infection also?
Sir, by definition, it is vaccinated people.
Only vaccinated?
Yes, sir. By epidemiological definitions, herd immunity refers to vaccinated people.
Secondly, when we say vaccine is 80% effective, what about those 20% people who don't develop antibodies? What they should do?
Sir, this we are not yet sure of, that to what actually they did not develop antibodies, because nobody is looking at the T cell immunity. So antibodies you will be able to see, but you can't say whether it is, those. But the vaccine definitely gives 100% protection. It claims to give 100% protection to severe disease. So you will get infected, but you will not develop a severe disease. And this we have seen also in the past 2 months. People who were vaccinated, amongst us only, we saw so many of us got infected, but we came out. And people who were not vaccinated landed up in a very in ICUs and in sad situations. So I feel the vaccine almost gives protection fully for severity.
Then we should, why we should say 80% if it is 100%?
It says that it gives almost 100% protection to disease severity. But no literature says in the world that there is a vaccine which will be 100% efficacious. There is no vaccine which says, or the manufacturer says that they are 100%.
My last question is, one of my patients who had COVID in the first wave, now it is almost 8-9 months, but the CRP is still 112. And should she get vaccination?
Sir, how many days has she become negative?
8-9 months back, she had COVID, and
so, but there is no data to support CRP with vaccination. I don't think I have not come across any data.
I think Dr. Sonal has given a very nice. Just wait for. I think we are getting a little time shortage.
Dr. Sonal, I'll like to ask you, with the given data and the present scenario, would you like to get yourself vaccinated with the booster dose? And this question pertains to every health worker. You have already received 2 doses of vaccine.
Sir, I have received 2 doses and I have received the natural dose also. So my vaccine titers were 19.5 day before yesterday. So antibody titers. So I don't know what to do with it. So I presume that as the booster government allows, I will take the booster, because I am so scared. I don't want to take any risk. If you ask me
will you recommend it to the government that you allow boosters to the
I think the government, the moment we have data to support that after 9 months or 12 months you have to give a booster, the government will definitely give that. Will come out with those guidelines.
Anyway,
So,
thank you.
Dr. S. Gupta, I think there are two questions unanswered. First question regarding the booster. Suppose one has taken Covishield or Covaxin and Pfizer comes, like, so in February next year, 2020, if health workers, care workers would like to choose Pfizer the booster, so would it recommend it? Would it be recommended?
So nowadays, with all the variants coming in, there is a lot of work being going on as to heterologous antibody production. That yes, change the manufacturer next time for the booster. But the thing is that in India, our vaccine is controlled by the government, and they will, if you know that your COVID app has captured your data from Aadhaar, so you will be given the vaccine what the government desires for you and
Right.
me. We will not be able to choose again. As
So if
somebody said,
we have a choice,
for booster also we will be the guinea pigs, as somebody said.
if any have a choice, if we have a choice, then would it be recommended? If you have a choice, okay, you can go for Pfizer or whatever.
Sir, पता नहीं, the grass is always greener on the
Right.
other side. और American grass तो हमें हमेशा से बहुत अच्छी लगती है.
Pankaj, I would like to answer this question. There was a very recent study which has been published about a few days back only, where the vaccine, the first dose vaccine, with the Johnson & Johnson or the Pfizer or the Moderna, and these patients were the renally compromised patients who were having immunocompromised, and they were receiving all sorts of immunosuppressive therapy because they were renal transplant patients. And when the third dose of the booster was given to these patients, those patients who had very low titers of antibodies, third dose of booster with the heterologous boost
Vaccine.
or by the same vaccine were able to augment the antibody titers, irrespective of the fact what sort of vaccine was the first vaccine. But those patients who were on immunosuppressive therapy and did not have any antibody titers, these vaccines, the third dose even was not able to produce any antibody titer. They can only boost. They cannot generate the antibodies fresh.
Right. So I think
I have one only comment, please. And after that, I will keep. The Gulf countries have already started promoting booster vaccination after 6 months of the second dose, irrespective of the antibody titers. We are unnecessarily harping on the antibody titers that mean nothing. But booster vaccination, that means the third dose of the same or different vaccine, the choice is left to the population, and they have already started it. And in fact, they don't allow people to enter their malls, and if they are not at the third dose, that is the booster dose.
Right. So I think that question has been answered well. The other question, the last question, Dr. Gupta sir, regarding the vaccination after natural infections who are having very high titers of antibodies, do they need vaccine?
We can't go on measure. It's a logistic issue. You can't go on measuring the antibodies and then. But generally, if you ask me, the microbiology perspective is that you allow the natural antibodies at least to go down below their threshold level. Otherwise, you're wasting the vaccine. Why does the government say that if a patient who has received convalescent plasma should wait for 3 months before he becomes, after becoming RT-PCR negative, and a person who's not received plasma, the GOI guidelines say 6 to 8 weeks after they become negative. So that is for the natural course of antibodies to go down so that you get the best benefit out of the vaccine and you get the best benefit out of your natural infection also. And they don't interfere and cause a kind of, you will only be increasing the side effect. I had a slide which said that there was a study which said that if you keep on giving the vaccine doses in infected individuals, only the side effects multiply. The effects will remain the same, but the side effects like fever and site pain at the injection site, they are much more higher reported in such individuals. I removed it because I thought that we are not going to talk about vaccination. So I kind of intentionally removed it.
I think
right.
Dr. Pankaj, it is the time to thank you, madam.
Yeah.
Thank you.
So, Rhoda Ashok, you can take over now.
Okay, thank you, sir. I thank Dr. Sonal Saxena, madam. Madam has presented very well regarding COVID-19 antibody and its response, and I think madam has cleared various doubts regarding the vaccine and their efficacies also. I thank Dr. Rahul Lathani, sir, for being here to chair the session and giving his wonderful discussion. And also I thank Dr. Vijay Arora, sir, for being here before me, and he started session. Thank you, sir, for being here. And I also thank Dr. S.K. Gupta. Sir has moderated the session very well and make the topic very interactive. I thank all of you very much, sir.